Good morning. Welcome you all to our course Radiation Oncology Physics, and today we are starting the 5th week of our course, where we will exclusively discuss the physical, technological and various other aspects of brachytherapy. Till now, most of the discussion we have done on external beam radiotherapy, but in radiation oncology we have a other than external beam radiotherapy, we have a treatment modality that is known as brachytherapy, and this modality of treatment brachytherapy is very important, and we are using a lots of patients for the treatment, and we are using brachytherapy for treatment of cancer, malignant diseases in radiation oncology department. And today the lecture number is 21, and we are going to discuss the principle of brachytherapy. Learning objective of this class: in this class we will discuss the definition of brachytherapy, the sites where we apply the brachytherapy, and we will discuss various advantages and disadvantages of brachytherapy methodology, and we will discuss the types of brachytherapy in detail, and we will also discuss the various kinds of brachytherapy source which are used for brachytherapy applications. Now, brachytherapy is a form of radiation therapy where sealed radiation sources are placed inside the tumor or close proximity of the tumor. So, brachy is a Greek word and the meaning is short. So, brachytherapy is short distance therapy. Brachytherapy also known as internal irradiation, because we apply the source internally within the target or within the patient body, and this is different from external beam radiotherapy, where the external beam radiotherapy is known as the teletherapy, means far distance therapy, where the radioactive source or radiation source placed away from the patient body and irradiate the tumor or target volume. So, there are very much distinct features are available in brachytherapy methodology, brachytherapy treatment. This brachytherapy, as we place the radioactive source or radiation source within the tumor, so we will give very localized irradiations, or means very conformal irradiations and around the radiation source, and we can give the very conformal type of dose distribution from the brachytherapy. And the second feature is we can deliver high dose to the target volume, and there will be a sharp dose fall off beyond the target volume, because the exposure or radiation exposure is directly inversely proportional to the square of the distance. So, the dose rate, the dose of exposure will decrease very rapidly if we travel from the away from the source. So, this is the cause we will get a very sharp dose fall off beyond the target volume. So, these three features is very attractive for treatment of malignant disease in radiation oncology department. So, in brachytherapy we use sealed radiation source which is placed inside or close proximity to the tumor, and brachytherapy is known as short distance therapy. Some other name is internal irradiations. Now, what are the sites where we can apply the brachytherapy? There are brachytherapy applied male and female in both for both genders, and these brachytherapy treatment applications we can perform from head to toe region, from head to toe, for male and for female malignancies. So, if we describe the treatment sites in detail, we can apply the brachytherapy in brain cancer, in breast cancer, cervical cancer, endometrial cancer, esophageal cancer, eye cancer, gallbladder cancer, head and neck cancer, lung cancer, prostate cancer, rectal cancer, skin cancer, and soft tissue sarcomas and vaginal cancer. You can see the whole we can use apply brachytherapy from head to toe. So these are the wide applications of, there is a wide range of applications of brachytherapy. We can use brachytherapy as a monotherapy, means a single modality radiation therapy, or we can use in combination with the external beam radiotherapy. So these planning that in some cases where we can use the as a monotherapy, or we can use as a adjuvant therapy or with the external beam radiotherapy. They are very much site specific, disease specific, and the stage specific, what is the stage of the disease. Now if we discuss the advantages of brachytherapy, we can categorize the advantages in three groups. One is we will get the physical advantages. We will get the physical advantages. Even we will get the radiobiological advantages of brachytherapy application than external beam radiotherapy. We will also get some logistic advantages of brachytherapy applications. We will discuss one by one. As I have already mentioned that a very localized irradiation around the radiation source, so we can confirm the target volume by our desired dose distribution. We can very conformably and very effectively irradiate the target volume, and we can deliver a very high dose to the target volume, and outside the normal tissue will get the lesser dose, as the sharp dose follow-up beyond the target volume is available for the brachytherapy applications. Now considering the radiobiological benefits or radiobiological advantages of brachytherapy applications, it is a continuous irradiations. We apply the radioactive isotopes and we keep these radioisotopes for some hours, some days within the target volume, and the dose is continuously, target volume is irradiated. This is different from the external beam radiotherapy, where we apply the fractionated radiations. Means we treat patients by fraction, and 5 fraction per week, or we distributed the whole dose in external radiotherapy in approximately 30 to 35 fractions. This is a normal convention. So in brachytherapy, it is a continuous irradiations. So cancer cell can move to the sensitive phase of cell cycle. Sensitive phase of cell cycles means, here we know that in cell cycle G2M phase is radiosensitive phase. In the external beam radiotherapy, as we deliver a high dose fractionated dose, so there may be some phase arrest or cell cycle inhibition there. So cells are blocked in certain phase, but here we use the low radiations, continuous irradiations, as we apply in the low dose rate brachytherapy. So cancer cell can move towards sensitive phase, G2M phase, and these cells are effectively killed by the radiations. And because of continuous irradiations, we can overcome the hypoxic radioresistant. In this point, I would like to mention that in tumor there are 3 type of component. One is oxic cell, and another is hypoxic component, and another is necrotic or dead cells. So these oxic components are very much radiosensitive, but hypoxic components, they are not radiosensitive. So if we can overcome the hypoxic radioresistance, we can achieve the better tumor control, and we can cure the patient. So, and we can reduce the overall treatment time, as the brachytherapy applications are for some days. So we can increase the effectiveness of our treatment, radiation treatment. Now logistic benefit, this is a short treatment time, means we need a very short hospital stay, and this is beneficial for patient and hospitals, and we can reduce the requirement of human resources, because there are very much specific persons are involved in these brachytherapy applications, and so it is also beneficial for if there is any shortage of human resources or everything, because in external radiotherapy we need to have a bunch of radiation professional who are involved in the process. The brachytherapy equipments are normally low cost equipment, so we can lower the treatment cost. So these are the logistic benefits of brachytherapy applications. Now, it's not in reality that everything is good or everything is merits with the brachytherapy. There are some demerits or disadvantages of brachytherapy also, because brachytherapy has the limitation to treat the large target volume, because there is a sharp dose follow-up, and the sharp dose follow-up is related that exposure is directly proportional to the inversely proportional to the square of the distance. And brachytherapy is an invasive procedure. Is any kind of invasive or surgical procedure is always complication prone procedure, whereas in external beam radiotherapy there is no invasive procedure is needed. In brachytherapy, as it is an invasive procedure or surgical procedure, we require anesthesia, and anesthesia has its own complications. So these are also one we can count as a disadvantages of brachytherapy. The tumor accessibility is very much needed for brachytherapy. We need to visualize by means of our palpation or by means of our surgical procedure or by means of our radiological imaging system. Tumor accessibility is very much needed, but sometimes tumor accessibility is compromised for treatment, and this is the limitations of brachytherapy. In earlier days, we use the low dose rate brachytherapy, we use the manual afterloading brachytherapy, where radiation protection is also a problem. But nowadays, we are using remote afterloading equipments, which are not, very much well protected in for the radiation. So this point nowadays may not be considered as a disadvantage. Now, dosimetry of brachytherapy is also very much complicated, and it's a very laborious to create one treatment plan for treatment of brachytherapy, because most of the time we use the metallic applicators and they cause the artifacts during imaging, and our treatment planning will be compromised because of these artifacts which are caused because of the metallic applicator. Now, this is a very important slide where we will discuss the types of brachytherapy. The brachytherapy is divided or subcategories as per various parameters or various type of as per if we divide brachytherapy by applications, the type of applications. In this terminology, if we categorize the brachytherapy can be divided in mainly 5 groups. First is interstitial brachytherapy, second is intercavitary brachytherapy, and third is surface mold brachytherapy, interluminal brachytherapy, and intervascular brachytherapy. Now, interstitial brachytherapy, we place the radioactive isotope directly to the tumor volume. So this is the interstitial brachytherapy. We will discuss detail in later slide. Intercavitary brachytherapy, in human body there are some natural body cavities are there where we put the applicators and we place the sealed radioactive isotope within the applicator, and we can irradiate the malignant disease of these natural body cavities. So this is intercavitary body brachytherapy. Now, surface mold is a superficial type of therapy where we prepare a mold which conforms the contour of the surface of the patient body, and we place the radioactive isotopes in this mold, and we irradiate the tumor superficially. So surface mold is treatment for superficial tumors, superficial lesions. Now, interluminal, we have also some lumens which are available in our human body, and we can place applicator and we can treat the disease of that lumen, and such as we can treat the esophagus. And intervascular brachytherapy, where we use the vasculature and where we apply our radioactive isotopes. So we will discuss detail later slide. Now, if we consider the loading or type of brachytherapy, we can divide this brachytherapy in two types. One is preloading and another is afterloading. Means some applicators, their already brachytherapy sources are inbuilt within this applicator, and we have to put this applicator in the within the patient body, and this is preloading, where radiation worker as a radiation clinician, radiation oncologist, radiological physicist, technologist, they will be get radiation from this type of application. So nowadays no one is performing preloading type of brachytherapy. Now we use afterloading brachytherapy, where the radioactive isotopes is placed after applying the applicator within the patient body in the OT, and we apply the radioactive isotopes within the applicator after this OT procedure. These afterloading applicator can be further divided in two group. One is manual afterloading and another is remote afterloading. So manual afterloading, the person need to apply the radioactive isotopes by hand, and it is also very radiation hazardous procedure. So this is also obsolete in nowadays. And another is remote afterloading brachytherapy, where the computerized system we can remotely operate, or you can remotely load the brachytherapy sources within the applicator from away from the radiation and from the radiation protected zone, that we can call these type of zone are very much controlled, where radiations are not much hazardous, and we can operate the machine from the controlled area. Now, if we consider the duration of the applications, we have two type of brachytherapy. One is permanent brachytherapy and another is temporary brachytherapy. Permanent brachytherapy, where we place the radioactive isotope permanently and we leave the patient, and they are short-lived radioisotope we apply in this case, and such as carcinoma, CA prostate and type treatment. And temporary applications, where we apply the source, and these source are removed from certain time, from certain treatment time. Now, if we consider the dose rate of the brachytherapy, can be subcategorized as low dose rate, medium dose rate, high dose rate, pulse dose rate and ultra low dose rate. These are 5 category by which we can subcategorize the brachytherapy applications. Low dose rate, the dose rate of the brachytherapy application is 0.4 to 2 gray per hour, then we call this as a low dose rate brachytherapy. If the dose rate is 2 gray to 12 gray per hour, then this is the brachytherapy application is known as medium dose rate brachytherapy. If the dose rate is more than 12 gray per hour, then we call this is a high dose rate brachytherapy. And ultra dose rate brachytherapy is the dose rate is 0.01 to 0.3 gray per hour. This is known as ultra dose rate brachytherapy. Such as this type of dose rate we get from the permanent type of implant, where very low dose rate brachytherapy is, we can consider this is as a ultra low dose rate brachytherapy. Now, pulse dose rate brachytherapy, this is the dose rate, this is coming by a pulse of radiations. We can give one pulse, and after 1 hour we can give again another pulse of radiations, and we can give another pulse of radiations. These are separated by 1 to 2 hours as per our requirements, and this combination of pulse dose rate is finally getting gives the results or effectiveness of low dose rate brachytherapy to get the radiobiological advantages of low dose rate brachytherapy. Now, considering the brachytherapy sources, first we have to define the characteristics of ideal brachytherapy source. Now, these are the some points which need to remember that what should be the characteristics or properties of ideal brachytherapy source. What's ideal brachytherapy source? The properties can be described by gamma energies, by beta energies, half-life of the radioactive isotopes, specific activity, physical parameters or physical properties, and availability. These are the parameters, these are the points where we have to define the properties of or characteristics of ideal brachytherapy source. Now, gamma energy should be monoenergetic. The gamma energy is ideally should be monoenergetic from this ideal brachytherapy source. But the range of the gamma energy should be 0.2 to 0.4 mega electron volt. This range is defined because of there is below this range we will have a bone shielding because of photoelectric interactions of gamma photons with the material mediums, and there will be a bone shielding by where we cannot achieve the good dose distribution below this 0.2 mega electron volt dose, and above this 0.4 mega electron volt we will have the problems of radiation protection. So, this is the ideal range of gamma energy of a ideal brachytherapy source. Now, there should be very low beta energy, and this beta energy should be cut off by filtration of the radioactive isotopes. Means the beta energy should be cut off by the encapsulation of the radioactive isotopes itself. Now, in considering the half-life should be low, very low for the permanent applications, and it should be high for the temporary applications, because we need to store the radioactive isotopes for the use of different patients. And in permanent applications, we want after certain times the patient, there should not be any amount of radioactivity within the patient body. Specific activity should be high, so that the specific activity is the activity per unit mass. This is the definition of specific activity. So, if we have a high specific activity, we can construct a very small source size, and we can small source size. The benefit of small source size is we can apply this small source to the small applicator, and small applicators are very much convenient to apply in patient body. So, we can have a very high specific activity to construct a small size source. Now, physical properties, thus ideal brachytherapy should be insoluble in any type of liquids, or it should be non-toxic. It should not a bone seeker. It should not catched by bone or any other type of organs, and there should not be any gaseous disintegrations. Means there should not any type of gaseous in radium we have a radon, which is a gaseous disintegration, and so we discontinue the application of radium as a brachytherapy source because of this problem. And radon is a bone seeker, and it is a gaseous disintegration. So, there is a problem of contaminations, and this gaseous contamination is very much complicated to handle. And the brachytherapy should not be in the form of powder or liquid form. And availability, it should be cheap and it should be easily available. Now, these are the brachytherapy source where we have mentioned that this is radium 226, the cobalt 60, the iodine 125, and the palladium, cesium 131, cesium 137, iridium 192. These are commonly used brachytherapy source, and their half-life, radium has a very long half-life, and cobalt 60 have a 5.26 years of half-life, and iodine have days, palladium also have days half-life, and so iridium 192 have 74.3 days. And these are the decay process of the brachytherapy sources, and these are the photon energies. And you can see all these brachytherapy are not complying the properties of ideal brachytherapy, and we commonly use the iridium 192 radioactive isotopes for wide applications of brachytherapy, and for permanent applications we use palladium 103 and 125, iodine 125. In some brachytherapy unit we use the cobalt 60 and cesium 137. So these are the brachytherapy source we commonly use. Now source is specified by different, we can specify the source strength, we can specify the source strength by equivalent mass of radium, and that is milligram radium equivalent. This is milligram radium equivalent because radium is the radioactive isotopes which are used in historically, they used very widely in earlier days. So for historical convenience we express our newer brachytherapy sources by the milligram radium equivalent, and this is the exposure rate could be expressed in terms of effective equivalent mass of radium, and exposure, this is actually exposure rate at 1 meter divided by exposure rate constant of radium at 1 meter. Exposure rate at 1 meter of a particular brachytherapy source divided by the exposure rate constant of radium at 1 meter, and this is the milligram radium equivalent. And if we consider the numericals, here is how to convert this one. This is mR per hour, this is the source strength of iridium 192, and exposure rate of radium is 8.25 R centimeter square per hour milligram, and if we convert this centimeter to meter, just this is 0.825, and effective milligram radium equivalent is 0.6 milligram. Now we can specify the source in terms of activity, but this is activity we can specify Curie or millicurie, and exposure rate or at any particular point is proportional to the product of exposure rate and the activity. But here is errors comes because there is the filtration and encapsulation is not considered in the this is the activity of bare source, but we use the filtration and encapsulations. So this reduce the activity and exposure. So we define the apparent activity. Apparent activity is the activity of a bare source of same nuclides that produce the same exposure rate at 1 meter, and apparent activity is the equal to measured exposure rate at 1 meter and exposure rate constant of unfiltered source. Now exposure rate at specified distance also be defined the source strength. This is NCRP recommends that source strength should be of any gamma emitter should be directly specified in terms of exposure rate in free air at 1 meter. And in current days we actually use nowadays the Ayer-Karma strength. Ayer-Karma strength is the product of Ayer-Karma rate in free space and the square of the distance of the calibration point from the source center along the perpendicular bisector, and unit is microgray meter square hour inverse. If we convert 1 milligram radium equivalent, we will get 7.227 microgray meter square hour inverse, and preferable detectors are well type chambers and ion chambers by which we can specify the source strength. And this is all from this brachytherapy principle of brachytherapy. Thank you all.